Hi, my name is Lisa Morad-McCoy. I'm a therapist with the School-Based Health Center at Highland High School and at Manzano High School. And I did a talk a couple of weeks ago on depression and suicide with teens. Today I'm going to talk about trauma and its toll on teens, children, and families and professionals. So the first chunk of the presentation is going to be specifically on teens and children, but then I segue into a little bit more about trauma and its effect on helping professionals, because I really think it's an important part of this talk. So this is a little overview. We're going to talk about some types of trauma, prevalence of trauma-related illnesses, and the big diagnosis in trauma, which is post-traumatic stress disorder, and then talk a little bit about trauma-informed care, and then, like I said before, a chunk of the last part of the presentation is going to be on secondary trauma. So I have trauma split out into different categories. There's primary trauma, which is, of course, when something bad happens to someone that you love or to you, and it's usually scary and dangerous, and it can be violent. Usually trauma is accompanied after we feel terror or helplessness and a feeling that you may not be able to survive the event. So obviously, some sexual assault would fall under that, physical abuse, a car accident, war. Those are all primary traumas. Secondary trauma are PTSD symptoms, and we'll talk about PTSD a little later, caused by at least one indirect exposure to a traumatic event. So that means if you're hearing about a traumatic event, if you are witness to a traumatic event, if you're witness to a traumatic event, that can actually be in primary trauma. But secondary trauma is hearing about it, having to talk to or be with people who've experienced trauma in years past, and then hearing their story. So that's where the helping professionals come in, and we'll talk about that later. Okay, complex trauma. And this unfortunately is a lot of what kids and teens experience, and this is usually why one of the reasons they seek behavioral health in their adult life is because of trauma that occurred in the past. So exposure to multiple traumatic events early in life. The trauma is usually of an invasive and interpersonal nature. So it's usually involving a caretaker, somebody that the child depends on. And it interferes with the child's ability to form secure attachment bonds. Because what happens when a child is faced with a caretaker who is abusive, emotionally abusive, physically abusive, neglectful, is they cannot come to depend on that caretaker over time, and then they're not able to form a secure attachment. And so this is kind of, attachment theory is really based in trauma in terms of the strange situation. I don't know if you guys have ever heard of the strange situation experiment, but where they had the babies and the mom inside in the room, and then they would take the mom would leave, and they would see how the baby reacted to the mom leaving. And a securely attached baby will become upset, when a caretaker leaves. And then when the caretaker comes back, will very quickly seek that caretaker and be soothed very quickly once the caretaker picks them up. In an insecurely attached baby, the baby will cry. They may cry when the caretaker leaves, and they may get disorganized and kind of upset, but when the caretaker comes back, they don't soothe very well. It's really hard for them to soothe back down. And sometimes if a caretaker leaves, if the caretaker leaves the room, then the child will have no reaction. So those are the children that we see that have insecure attachment bonds, and that can lead to a lot of different things, PTSD symptoms, reactive attachment disorder, all of that. That's kind of a whole nother talk, but it's part of trauma. It's what you see a lot for kids who've been through trauma. So traumatic grief. This is kind of a specific kind of trauma that occurs. So you can have a teenager, for example, who has a pretty normal life for the most part, and then somebody dies in their support system, and the death could be traumatic. So they go through this form of trauma called traumatic grief. And it's usually because of how the child or teenager perceives the experience, and it's usually that they perceive it as traumatic. For example, I'm working with this person right now who recently had a death that was not violent, but it was unexpected. The father had a heart attack, and it was related to complications related to diabetes. And so although he was sick for a really long time with diabetes and complications related to it, nobody expected him to die. And this person came home and saw his father's face. And so now he's really struggling with these images of his father's face on the day that he died, and he can't get those images out of his head. So so right here it says thoughts or reminders, even happy ones, can lead to frightening thoughts or images. So now he's faced with, every time he thinks about his father, he gets these images and he can't even enjoy happy memories of him. So that is traumatic grief. And it's difficult because these kids kind of get stuck there, and it takes a long time to help them integrate the loss into their life. And it can take years, unfortunately. So, okay, some statistics. Trauma is such a big topic that it was hard to find statistics of just traumatized children. So I kind of split it out a little bit. In 2012, there was a study where 1,600 children died from child maltreatment. That's 2 out of 100,000 kids, which may not seem like a lot just on the surface, but these are the kids who died. There's a lot of other kids who are going through child abuse and neglect and other forms of maltreatment that survive. And so the second one shows that a little bit. So almost 700,000 people, victims of child abuse and neglect, reported to CPS. That's a lot of reports. And yeah, some of them are probably, I can't remember if the statistic was one where the cases were substantiated or not, but that's still a lot of reports. And then about in 2015, the number jumps a little bit, but to 1,670 died from child abuse or neglect. So these are pretty, scary numbers. And one of the things that happens with trauma is that it's intergenerational. So you may have a family who has a lot of different factors, like they might have poverty, they might have parents with mental illness, there might be drug abuse, and then because of those factors, abuse starts to occur in the family, and then that family has kids, and all of those, if it's not treated, the complex aspects of trauma just keep getting handed down from one family to the other. And so that's why trauma, again, it's just a really big topic. And there's a lot of different offshoots that you can study in trauma. So this is just kind of a snapshot. Okay, so childhood trauma statistics. So a lot of this is taken from the Presidential Task Force on PTSD, and they're kind of old stats, but these stats, I think they're pretty on target with what's going on now. I wasn't able to find anything related to PTSD itself, but so between 25% and 43% of children are exposed to sexual abuse, between 39 and 85 to community violence. Over half of children report experiencing a traumatic event by age 16, and that's a lot. So that's why if you're in this field, trauma is going to be a big basis for diagnosis and treatment with whatever you do. Okay, so the total lifetime cost of child abuse and neglect is estimated $124 billion a year. So we spend a lot of money on this, unfortunately. And okay, let's see. Okay, this is sort of the more fun part in terms of the presentation. So there was this study back in the 90s that studied adverse childhood events. And it was a really groundbreaking study because, and it may seem, the results may seem pretty, what am I trying to say? The results may seem pretty obvious, but basically what the results were is the more adverse childhood events that a person has, the more likely they are to develop physical or mental illness in the future. But what was interesting is they split out into 10 different categories of adverse childhood events. So these are some of them. I kind of cluster them together. So abuse, witnessing domestic violence, accidental or intentional death of a family member, and then in the household, substance abuse, mental illness, and incarceration of a household member. So with adverse childhood events, it's not necessarily one specific trauma, like somebody gets in a car accident and 3 people die in a family. But this is every day. Substance abuse every day in a child's life, mental illness every day in a child's life. It becomes common for some kids to have family members incarcerated. So they kind of get used to this ongoing, difficult, traumatic lifestyle, and it can cause a lot of problems later. So these are some of the problems that it can cause. These kids, as they get older, have a higher instance of all of these different things: heart disease, cancer, diabetes, substance misuse and abuse, depression and anxiety, and suicide attempts and completion. So it makes sense to study this and treat these kids as we can. What's difficult about it, again, is that these kids are in these families and it all feels sort of normal. Like, they don't necessarily feel traumatized. So, you say to a kid, like I've done this before, you've had a really tough life, like things have not been easy. And they look at me like, well, what do you mean? Because it's always been like that. They don't have they don't have anything to compare it to, but it really does cause these chronic problems later. And I apologize for my voice. I've been fighting a cold, so just bear with me. Okay, so PTSD, and that's one of the biggest diagnoses you're going to see with these kids and families. Now, the thing with PTSD is that it can be overdiagnosed. You have to have a child or a teenager has to have had traumatic event in order to have PTSD. And it's not necessarily whether we judge it, whether it's traumatic or not. It's whether they do. So they have to perceive the event as traumatic. So precipitating factors, so the traumatic event or watching a traumatic event. What's interesting about this is some of the kids with who have witnessed domestic violence in their family have some of the most serious PTSD symptoms, even more than kids who have been physically or sexually or emotionally abused themselves. And it makes sense, because if you were going to go through something, would you rather watch a loved one go through it, or would you rather go through it yourself? And most people would say, just, let me deal with it and save this other person. Well, children feel really protective towards their caretakers. So when they are being hurt, it's really traumatic for them. And then learning about a traumatic event and experiencing repeated or extreme exposure to adverse details of traumatic events. So that's more on the lines of secondary trauma, and we'll get into that a little later. Okay, so PTSD is kind of split up into 3 clusters of symptoms, and the first are intrusive symptoms. So PTSD can look a lot like anxiety, and anxiety is part of PTSD. It's a symptom of PTSD, but it's the flavor of the anxiety that's the important thing. So it has to involve distressing memories of the event. Or with kids, you see repetitive play, where they're reenacting the trauma, or they also draw pictures of the trauma, and they kind of do it over and over again, and it's pretty remarkable. So with that, you can say, okay, this kid isn't just anxious. There's more here, and it might be related to trauma. So frightening dreams without recognizable content. It's a little bit of a myth that people with PTSD have dreams about what they've experienced. A lot of them just have a panicky, frightening feeling without being able to say what it is. And then when we talk about flashbacks, that's usually what occurs when a child or an adult is not sleeping. And a flashback is different, because a flashback is a memory, a very real memory of the event. So they are back there. And that's when you may see teens or kids dissociate. If you're talking to them, they kind of go somewhere else. You can see it in their face and in their eyes. They're probably having a flashback or some kind of dissociation. Reacting to triggers, so internal or external cues that are reminders of the traumatic event. So, for example, I used to do groups for kids who have had sexual trauma, and I used to bring strawberries to group on occasion, or fruit, but one day I brought strawberry, and one day one of the members came to me and said, can you not bring strawberries anymore, because just the look and the smell of the strawberries took her back to a traumatic time. So it's really interesting that things, and you don't even really smell strawberries that much normally, but she did, and for her it was hard. So it takes on a life of its own at times. Okay, and then what you see a lot of times is avoidance of external reminders. So taking a different route, so you don't have to go past a house or past a street where something happened. So those are the intrusive symptoms. So thoughts and mood. Difficulty remembering details of traumatic events, blaming self for the event. This is so common. And actually, in the kid that I was talking to you about before, who had his father die, this is one of his biggest issues, is that even though, you know, his dad had a heart attack and there's nothing that this person did to obviously it's not his fault. He's blaming himself for all different aspects of his father's death, not being at home, being at football practice, all these different things. So it's amazing how your brain can play tricks on you after a trauma has happened. And this is a kid who really had very little symptoms of anything prior to the event. And now he's really struggling. So persistent fear, anger, guilt, and difficulty experiencing positive emotion. So it's almost hard, and this comes out in traumatic grief because people feel guilty for being happy after somebody that they love has died. Okay, so increased arousal. You see this in a lot of younger kids, but you can also see it in teenagers too. So exaggerated startle response. So jumpy kids that jump when a door slams, or they have to be looking around and watching everything to make sure everything's okay. Outbursts. And sleep problems are big too. Unfortunately, sleep problems are just so pervasive that sleep problems can look like anxiety or depression as well. But it could be PTSD. Okay, so I'm going to transition to trauma-informed care, but before that, I just want to say that I didn't put a slide on assessment in here because trauma assessment there's a lot of different ways to go about it, and a lot of agencies do different things to assess for trauma. But it's very important to assess for trauma because you may see a kid who's like has even psychotic features like psychosis, so I've seen kids be misdiagnosed with really big diagnoses like schizophrenia and bipolar disorder, when really when you dig, or when the child is ready to disclose, usually these symptoms are related to trauma and not that they have this really big mental illness, which can sometimes be a relief because, you know, a diagnosis of schizophrenia or bipolar disorder is not a great thing. So trauma, that's where we get to trauma-informed care too, because basically what trauma-informed care refers to is having an aura of safety and an aura of, we are going to assume that you may have been traumatized, and we're going to proceed in that way so that and we're going to be transparent, collaboration, empowerment, and but the biggest thing is that's why I have it on top is safety. They have to feel safe. That's what, you know, and that's partly where Safe Zone came from. That's why we have Safe Zone posters all over the school-based health center, is because when a teenager comes into my office and sees that sign, that's an immediate symbol that I'm an okay person to talk to, and that my approach is going to be safe and trauma-informed, hopefully. Hopefully that's what happens. And transparency is really important because kids who've been traumatized are very hypervigilant, and so they can sense when you're not being real or when something isn't right to them. They have a very heightened sense of what's happening and people's feelings. And then the last one here, empowerment, is that's where you get to the part of trauma reintegration where, yes, I've been traumatized and it's difficult, and I'm also able to function in my life because I've let go of some of the self-blame. And that takes years. Like I said, this is a diagnosis that takes years to feel better, and it's really cyclical. So there will be times of feeling better and then times of dipping back down into more symptoms. Okay, so trauma treatment. So the two treatments that I have up here are, this is one of them, attachment and behavior catch-up, ABC. They're both based in attachment theory. Attachment theory is a great theory. It's one of my favorite theories in when I do when I do therapy. And it's not that there's any specific techniques. There are, but it's just seeing this person as part of an environment and a family, and how they came to view the world. Are people safe? Are people not safe? Do they feel secure about their environment? Do they feel insecure? And a lot of it comes from early childhood. And this ABC treatment is really for little kids and their families, so like 2-year-olds. And it's attachment based. There's an emphasis on the neurobiology of stress, so cortisol levels in the brain. So what it does is it teaches parents to nurture children. And that may seem, well, what's so hard about that? But a lot of parents are unable to nurture their own children because they have an attachment disorder. And so it teaches parents to, even though I don't necessarily feel this way, I don't feel like holding my kid and hugging my kid, I'm going to do it anyway. Because parents can become triggered when they are giving affection to their children. So if they've been traumatized, they give their child a hug, they become triggered, and so then they avoid doing it. I'm making it really simplistic, but that's just to explain the theory. And the hope is that over time, the parent and the child can become more attuned. And so the parent can say, oh, your face looks like this, so I think you need this. Or you're starting to cry like that, and so I think you're hungry. Or I think you need a hug. And it regulates, this technique regulates parent and child behavior. It's kind of amazing. Like, you see children regulate, but you also see the parents regulate. Because a lot of times these parents have never gotten any help themselves. And it's done in the home. And like I said before, it's known to decrease cortisol levels in young children. So this is another one, attachment, self-regulation, and competency arc. Again, it's based in trauma. This is sort of a continuation of ABC into the teen and adult years. It's very good with complex trauma. So it takes complex trauma, and it really helps people self-regulate and learn to organize their life in a way that they don't get triggered as often. So the patient profile often includes ongoing exposure to the adverse childhood events. So these are these really, traumatized over time families and kids. And so the overall goal is to make the whole support system trauma-informed, just like we talked about before. And some of the things that, some of the ways it looks in therapy in terms of techniques is establishing routines and rituals. So making sure that an appointment time is the same time every week or twice a week, so that that is a given, and that the kids don't have to guess when they're going to see this person that's their therapist, because a lot of times these kids have had to guess, when am I going to have somebody care about me? When am I going to, is there going to be food at home? Is my mom going to be asleep on the couch or getting high? Or is she going to be doing, something that isn't traumatic or scary? So really basing the treatment in something that the child can hang on to, and then structuring sessions so that the child knows what to expect. For the first 15 minutes, for example, we're going to do a check-in. For the second 15 minutes, we're going to play a game. For the third 15 minutes, we're going to talk about something that was difficult, so that they know and it's not a big surprise. And so ARC is based in 4 domains: attachment, self-regulation, competency, and trauma experience integration. So self-regulation is about emotional regulation and teaching those skills. As a clinician, one of the things that I most appreciate is learning different techniques to help people self-regulate. There's a lot of them out there. There's an exercise called the 5 senses, which I use a lot at the school-based health center. I didn't put it in here, but just look it up. It's online, it's everywhere, and it's a way to settle people down, help them emotionally regulate, and bring them back into the room. And then they feel good because they've been able to do it themselves. A lot of these kids feel really out of control, and they don't want to feel how they feel. And then the fourth one, trauma experience integration, is bringing it all together. And one of the most complicated parts of trauma treatment is helping a child or an adult integrate the trauma into their life. So it's not this compartmentalized part where they dissociate off to, but they can integrate it into their life. And it's really hard. I even have a hard time explaining it to families and kids, because how do you really integrate a scary or hard experience, or constant experiences with the ACEs into your life? It's difficult. Some of these kids have to abandon their family, and they have to learn how to make a new family and learn how to just kind of start all over again. But this is a good treatment. It's versatile. It can be used in a lot of different settings. You can use different pieces of it. There's a great book out there that just details the technique or the model, and it's Margaret Blaustein who's the creator of this. Okay, so other treatments for trauma. So, these are just the basic ones: cognitive behavioral therapy. A lot of times with behavioral therapy, what we have to do, especially if a person has experienced a single trauma, like for example, they got in a car accident driving on a highway, and now they don't want to drive on the highway anymore. Well, systematic desensitization is going to be what to get them to, so that they can start driving on the highway again. And I'm using this example because it's an easy example to explain. But what you do in a therapy session is you walk them through, okay, how would it be? What would it be like to drive down, Paseo del Norte and get on I-25? And you really get specific as the therapist, what they're gonna see, and you start to elicit panic symptoms. And you want that because you want them to experience panic symptoms in the room and say, look, you were panicky right now, and this was really hard for you, but you ended up being okay. And over time, that kind of systematic desensitization can really help. Again, that's more for a singular trauma rather than the kind of pervasive complex trauma. Group therapy is great for all kinds of trauma because, especially with kids, they listen to their peers. And so they're more likely to get something out of a peer saying, yeah, I felt like crap for the first 2 years of my life because of this, and now I'm feeling a lot better. And then narrative therapy is a very complicated therapy for trauma. It's basically letting the kid and you as a therapist write down the details of the trauma. I would definitely look into this more before I even attempt it, and learn about it, and maybe even get certified in it if you're interested. So, secondary trauma, also known as compassion fatigue, vicarious trauma, and burnout. Okay, so this is like this is the second part of this training where I talk about secondary trauma, being a helping professional in a field where you're working with a lot of trauma. It's difficult, and it's important to know the symptoms as a helping professional. And I know you guys are students, but I'm assuming some of you may have been in the field prior to now. Secondary trauma signs and symptoms: avoidance, not taking phone calls when, like, your client phone calls when they're calling you; social withdrawal, just going home and eating pizza and watching TV every night; anger, cynicism, insensitivity to others' pain and trauma. So you start to get numb, like you start to hear all these stories, and it doesn't really make much of an impression on you anymore. And some of that is protective and good, because we don't want to be crying all the time with our patients and clients. However, if it gets to the point where you're just like, oh, another horrible thing happened, and you find yourself not really caring about it, that's the time to start to get help. Chronic fatigue, poor boundaries, and loss of creativity. The loss of creativity is an interesting one because that's very subtle. It's like you just want to go to work and do your thing, and you don't want to do anything else beyond that. Somebody asks you to do a presentation, and you're like, you look at them like they have two heads. So just those are some of the symptoms to watch out for. Oh yeah, this one. So self-awareness is the most important factor in this, okay? And that's pretty, self-explanatory. And so the video that I am going to show it's about a 20-minute video, and it's not necessarily part of the presentation, but you can watch it as a part of it. I'm not sure. Kevin will help with that, but it's the link is in the presentation. Anyway, the presenter is Laura Vander Lipsky. She has a book called Trauma Stewardship. It's a great book. It talks about how to handle secondary trauma and ways to deal with it. Because what happens in social service agencies and medical agencies, helping agencies everywhere, is that if people don't take care of this, they start to act out their own symptoms and their own secondary trauma. It comes out in gossip. It comes out in being really angry and cynical about what you're doing. And it just isn't, it makes it really hard to go to work every day. So this is important. And I know this isn't about teens, but if you work with any population, secondary trauma is going to come into play at some point. And so here's some websites. I got a lot of the stats and stuff from this presentation from NCTSN, the National Child Trauma, I forget the last two letters, but it's a great website. It really is. It has got a great plethora of information. And then that's Laura Vandernoot's website, traumastewardship.com, and you can see a picture of the book on that website.